Hello everyone, and welcome to the first session of our 2026 AI Connect series. I am Tendü Yoğurtçu, leader of the AI group within the TÜSİAD New York Network. I also serve as Chief Technology Officer and Board Advisor. It's a pleasure to be here with you today. At TÜSİAD New York Network, our goal with the AI Connect series is to foster a global dialogue on AI's impact on business, economies, and society. Through these conversations, we bring together business leaders, innovators, experts, and decision makers from the United States and Turkey. Today's session focuses on AI in healthcare. Artificial intelligence is rapidly reshaping healthcare across clinical trials, diagnostics, precision medicine, and research operations. At the same time, the gap between promising research and real-world operational impact remains significant. We will explore a central question. What is AI actually delivering in healthcare today, and what will it take to move from pilot projects to scalable, measurable outcomes? And to do that, we will have a very distinguished guest joining us today. We will have about 10 minutes Q&A at the very end. Please share your questions through the chat window so we can actually compile that as we go through. Let me introduce our distinguished guest. We are honored to have Dr. Ümit Topaloğlu. Dr. Topaloğlu is Chief of the Clinical and Translational Informatics branch at the National Cancer Institute, where he leads AI and data science efforts supporting clinical research, precision medicine, and real-world data initiatives across National Cancer Institute and National Institutes of Health. His focus is on making AI usable, trustworthy, and scalable in healthcare and cancer research. He is also the founder of FLAME, a national federated learning consortium, and a fellow of the American Medical Informatics Association. Ümit, thank you for joining us today. I'm looking forward to the conversation.
Thank you, Tendü, for the invitation, and TÜSİAD as well. Before I start, I would like to indicate that I'm here today in personal capacity, and views that I'm going to share is my own, not NCI's. With that, let me share my screen.
Ümit, healthcare is everywhere in AI conversation right now. Before we look at specific use cases or discuss some of the opportunities, I want to start with the bigger picture. From your perspective, why does this moment feel different from previous waves of healthcare technology?
Thank you. So, because the first time, in my opinion, two things are true simultaneously. The workforce crisis has made the status quo genuinely untenable. We cannot recruit our way out of a physician burnout or staff our way out of rising demand, right? So, and the models have finally matured, secondly, enough to be deployed at clinical scale. You needed both conditions to be true at the same time, and we now have them. And also the macro numbers reflect that. $100 billion projected in healthcare AI investment by 2030. That's not a marketing figure. It's institutions voting with capital because they see no alternative path forward. But the urgency cuts both ways. When the pressure is to act this high, the risk of deploying poorly is also very high. That's what this talk is about, and not the promise, but the proportional evidence. What actually works, what doesn't, and what it takes to deploy responsibly. Let me start with an analogy. I see AI as an excavator. The replacement narrative that you may have heard over media, diagnosis is wrong. Physicians were not displaced by other physicians. They were displaced by paperwork, by prior authorizations, by documentation requirements, by inbox management. Administrative burden didn't arrive all at once. It accumulated over 40 years, layer by layer, until it buried the patient encounter. So if that is the problem, the solution is not the replacement, it's an excavation. AI job, in my opinion, is to remove what is in the way so physicians can get back to the work that cannot be delegated. Those are the physical exam, the conversation, the moment of listening to patient, fear, and deciding what it means. Every use case I'll discuss today should be evaluated against this question. Does this give clinicians more time with patients or less? That's the only frame that matters, in my opinion.
Ümit, thank you. I really like that excavator frame. I have never heard that word being used, by the way, but it's useful because it gives us a way to evaluate what's actually working. And let's look at the evidence. You have multiple use cases. Where are you actually seeing AI create measurable impact today?
I think the clearest evidence is the ambient AI scribes. Physicians currently spend 2 hours in the EHR, which is electronic health record systems, for those who may not know, for every 1 hour of direct patient care. The ratio is not sustainable and it's not acceptable. It means the majority of a physician's working day is documentation, not medicine. In 2025, New England Journal of Medicine AI published a randomized clinical trial with 238 physicians. 2 platforms tested head-to-head against usual care. This is important. It's a randomized trial, not a vendor case study. Nabla users saw a 9.5 decrease in time in node. Both platforms showed measurable improvements in burnout, task load, and work exhaustion. The effect size are modest, but they are consistent across specialties, and they point in right direction. The trial also found something that cannot be glossed over. Clinically significant inaccuracies were noted occasionally across both platforms. That is the operational reality of ambient scribes. The liability implication is straightforward. The physicians who sign the note owns the note. The AI doesn't sign anything. So review is not an optional, and it cannot become a rubber stamp. The efficiency gain from ambient scribes comes with a corresponding responsibility for vigilance that does not go away. These tools reduce burden, they don't transfer responsibility, in other words. Still, in the category of what is emerging rather than what is established is conversational AI in clinic. In 2026 feasibility study, 100 patients interacted with Google's Amy conversational AI before urgent care visits. The differential diagnosis included the final diagnosis in 90% of cases. No safety stops were required. What I find most interesting is the patient attitude finding. Before the interactions, patients were skeptical. After, they were not. You cannot brief patient into accepting AI-assisted care, but a good interaction changes their view. That has real implications for how your sequence roll out. The caveat is, however, this is a feasibility study in a controlled urgent care settings. Complex multimorbidity patients in a high acuity environment are a different test entirely.
Ümit, I'm sure that a bad experience also changes, and regardless of that bad experience is with AI or a real human being, it's human psychology, right? The more service we get, the better experience and positive, more accepting behavior develops. That's very interesting. This agentic AI experience in the surveillance, oncology surveillance, how does that differ operationally from the ambient scribe model that you shared earlier?
So it's architecturally, they are completely different, right? The ambient scribes are passive. They transcribe what is said in the room by physicians and patients. The IRAE agent at a Mass General Brigham is active, for example. It's continuously ingesting EHR data assembling evidence, and routing a proposed clinical judgment to a human clinician for sign-off. As a disclaimer, I am a collaborator in this work that I'm presenting. The clinical context matters. For instance, IRE, immune-related adverse event from immunotherapy, are time-sensitive and symptom-diverse. They can look like almost anything in a busy oncology practice. Monitoring every patient's notes for emerging IRAE signal is a task I don't believe a clinician can sustain at a scale. The volume exceeds human bandwidth, in other words. The validation results speak for themselves. As you can see the numbers, the detection macro F1 of 0.88 and precision of 0.95, both surpasses established human gate thresholds. And critically,
Ümit, I don't mean to interrupt you. Tell us in simple terms, if I was not a medical person, what does that 0.88 and 0.95 mean? What is it telling us?
So those are the amount of when you are testing, when you get, how can I say, results from EHR, what percentage of the true positive or your model is representing is the accurate one versus the precision is overall how many of those truly presented in EHR captured by your model, very simplistically. I don't know if that answers the question.
That does. Thank you.
So moving on to the agentic framework or surveillance, team extends to population health, as you can imagine. Deep learning models using wearable data can predict ICU transfers and cardiac arrest up to 17 hours before standard clinical alert triggers. And standard alerts fire when the patient is already in trouble currently. These models fire when there's a still meaningful intervention space. And population-level LLMs frameworks are now predicting biological age from routine clinical records, outperforming traditional aging clocks in a mortality prediction. That's not a research curiosity. It's a signal that routine data contains more actionable information than we have previously been able to extract. In other words, AI adds value at the surveillance layer, finding signal in data volumes no individual clinician can monitor continuously. The judgment call still remains in human, but AI gives judgment call a better information basis.
That's great. And for those of you who joined us last year in our AI agent session last year, this is what that thesis looks like in practice. Because let's pause here for a second and pull together what we just heard, because Ümit covered a lot of ground and very interesting use cases. We saw three very different ways AI is showing up in healthcare today. The first is reducing the documentation burden on physicians through ambient scribes, example he gave, where the promise is significant, but accuracy still requires human review. The second is AI that actively monitors patients in real time and helps clinicians identify risks earlier, like the oncology surveillance example that was shared. And then the third is AI supporting diagnosis and predicting health risks across very large volumes of patient populations, which we were not able to do before. We were not able to analyze these populations and these volumes of data previously. What connects all three is the same question Ümit framed at the very start when he started speaking. Does this give the clinician more quality time with the patient? Or does it introduce additional layer of complexity? And that becomes an important lens for the next part of our conversation here, because many of these systems can work very well technically, yet still struggle to create impact operationally at scale. With that, a lot of the challenge in healthcare AI seems to come more from the workflow, the adoption, and operational experience and integration. Ümit, can you walk us through that, please?
Sure. So you may have seen this every 1 hour spent perfecting a model, expect 4 hours of implementation work. Data pipeline engineering, governance structure design, workflow redesign, change management, legal and compliance review are some examples of that 80%. Less than 20% of effort, in other words, in successful AI deployment is just the model development itself. The other 80% is everything else. I think this has a direct implication for how institutions evaluate AI tools. A vendor who leads the benchmark metrics and cannot tell you anything about their implementation support model is showing you exactly where their priorities stop, right? The model is the smaller part of what you are getting, in other words, as you nicely alluded. It also has an implication of timelines, right? Institutions that plan for model deployment, where there might be a very promising model, without planning for socio-technical work, will constantly going to result in underestimated cost, underestimated time, and overestimated readiness.
Ümit, this is very interesting. 80-20, I found this data remarkably similar to other industries as well, by the way. It's a challenge. Operating model seems to be a challenge for many of the industries. So what happens when something fails?
Yes, so maybe I can start with an example. In 2023, you may have seen, some of you at least, in 2023, a widely deployed sepsis prediction algorithm flagged a patient as high risk. Nursing staff dismissed the alert because they had seen too many false positives. The fatigue was structural, built up over months of over-alerting. The patient deteriorated 6 hours later. In this particular case, the algorithm was not wrong. The workflow was. The fix at that institution was not the retrain the model, it was the redesign where the alert went. Fewer alerts, higher specificity thresholds, direct escalation to a charge nurse instead of general inbox. That has resulted false positive to drop around 40%. In other words, alert fatigue is not a technical failure. It's a deployment failure. And it's entirely predictable when a high sensitivity model is placed into a workflow that was never designed to handle its output volume. In other words, the bottleneck was never the model. It was the 3 a.m. inbox nobody checked was.
I love this example for a couple of different reasons. Not because somebody had a unfortunate outcome, but it shows something very important when we are thinking about implementing artificial intelligence, and especially the agentic, more decision-making versions of AI in our existing workflows. So if we look at here, we ultimately changed the workflow because the workflow had a problem. The escalation was going, it was just going to a 3 a.m. inbox, as you mentioned. They had to change that to escalate to a charge nurse. They had to also monitor the fever alerts versus volume of less quality alerts. But there was a workflow change as well. In your experience, what separates organizations that successfully operationalize AI from those that stall after pilots?
So thanks for that question. So the organization that stall almost always have the same profile. They have strong model, weak adoption plan. AMA's 2024 digital health research found that while 65% of physicians express enthusiasm for AI, nearly half report concerns that these tools add to their administrative or cognitive burden rather than reducing it, which you touched earlier. That is counterintuitive, but it makes sense when you understand why. Learning a new system has a cost, and most institutions don't protect clinicians from that cost during the transition. The industry is at a crossroads. The promise of AI is burnout reduction, but early implementation data suggests that without proper workflows integration, these tools can actually increase cognitive load by creating a new inbox, for our previous analogy, for clinicians to manage. In other words, time to proficiency for ambient scribes averages 3 to 6 weeks. And most pilots don't survive long enough to clear that threshold because the pilot timeline was or usually never designed within the learning curve in mind. What works, in my opinion, is the champion model. 2 or 3 early adopters per department, given protected time and institutional visibility should be there. A feedback loop that closes so clinicians who report errors see those errors resolve within a defined time frame. When a trusted colleague, in other words, is using the tool and talking about it in rounds, then in my opinion, adoption will follow. So question nobody asks at Go Live is, who owns after launch? In most institutions, accountability is split between IT department, clinical informatics, or the vendor. And that ambiguity is where post-deployment performance goes to die.
That is very insightful. I like the champion model here because ultimately you are saying you have a couple of people who are the power users of these, and they show the benefits so that other colleagues can also be inspired to use these and use with their judgment, of course. Judgment is the overarching, I think, theme that you are talking about. And human judgment is going to stay very critical, especially in an area like healthcare. The stakes are very high. When does governance become as important as the model? And when do you see that happening, Ümit?
In my opinion, it's from the day one of deployment, but it becomes visible as a patient safety issue the first time a model drifts without anyone noticing. In other words, drift is invisible until it isn't, right? Models decay silently, EHR templates change, clinical documentation patterns shift, vendor API updates push new model versions without institutional revalidation. The model that passed your governance review at Go Live may not be the model running 6 months later, in other words. So validation is not a one-time event. It's a perpetual service obligation. There are some examples like FAIR AI framework gives institutions a prescriptive structure for this. Pre-implementation review criteria, post-implementation performance monitoring, and defined escalation pathways when performance degrades. Most institutions have no designed owner for post-deployment AI performance. That gap is where patient safety incidents occur, in my opinion. So let me continue some other examples of governance framing. And in my opinion, governance is a living system, not a document that you file at the beginning and forget, right? The continuous cycle, like deploy, monitor, review, update, or retire, is what institutions that scaled AI successfully actually operate. So some has AI inventory as a practical foundation, and a live register of every active model, a validation status, ownership, last review, update needs to be tracked in that inventory. Let me move on due to time, I guess. So probably we need to consider 3 questions on the responsibility aspect. First, an AI scribe produces an inaccurate note that informs a clinical decision. Who is liable in this case? Current legal consensus is the physician who signed the note is liable. The documentation trail is everything. Second example is the predictive model fails to flag a deteriorating patient. Is the hospital liable? Emerging case law suggests yes, particularly if the tool was marketed as a safety net. If your vendor contract describes the tool as a safety mechanism, you may have accepted liability exposure your governance team has not priced. And third, the vendor updates model via API without institution revalidation. Who bears the burden? This is currently unresolved. That is the drift problem we just talked on previous slide, with legal stakes attached. So you may have heard the EU AI Act, which is now enforceable in 2026, classifies most clinical decision support as a high-risk AI. Conformity assessment, human oversight, documentation, post-market surveillance. These are now legal requirements in the EU and leading indicators where US regulation is heading. So institutions action available right now, contractual indemnification clauses that addresses model updates and drift. Let me move some other examples, and one of my favorite, federated learning. So as you can imagine, the data pipeline is the foundation. A model is only as good as the data feeding it or training or fine-tuning. Moving from retrospective research data set to millions of real-time free text clinical note is a different engineering problem. This is where federated learning is the right architecture, where data sovereignty is non-negotiable. And for time, I'm going to skip some slides quickly. The validation, the ask for everyone should be the same. Show prospective outcome evidence, not a benchmark performance. And we need to connect the economic case to what finance team actually track: revenue cycle, labor productivity, and avoidable cost. I think that's how we can have institutional and community buy-in that will survive beyond the pilot phase. And according to an ONC's Office of National Coordinators 2024 data brief, over 70% of US hospitals are now using a predictive AI, and vast majority of them are using their EHR vendors as their primary gatekeeper for these tools. We are seeing a consolidation of capability. That is the path of least resistance. It's not necessarily the path of best clinical outcome. EHR vendors have the infrastructure advantage, but they are not always the innovation frontier for specific clinical use cases. And the 4-point vendor evaluation that you are seeing on the screen, in my opinion, should give you the idea of how we should approach it.
Ümit, thank you. Let me bring this together before we look ahead. What Ümit is describing is that the technology is often the easier part. Of course, it's not as easy. It has taken over 50 years to come to this point of trust with AI and the skills and decision-making we were able to develop. However, it's the easier part when we are deploying these at scale, especially with highly regulated industries. The harder work is everything around it, connecting fragmented data systems, making sure AI continues to perform actually accurately over time, building governance that's continuous rather than one-time approval process at the very beginning, and getting clinicians to trust and adapt these tools in daily practice. I will give you a personal example of why data foundations matter so much. Here in New York, if I get a scan at one hospital and need to see a specialist at another hospital in the same city, and sometimes even in the same hospital group, I may still need to carry a physical copy of that scan with me because the systems cannot fully see each other. The data remains siloed. For those of you in Turkey, through e-Devlet, health data is already far more centralized nationally. That creates a significant structural advantage for healthcare delivery, coordination, and ultimately AI adoption. But the broader point is universal. Until organizations modernize the underlying data foundation, they will struggle to fully capture the value AI can deliver. For those of us leading organizations, the takeaway applies beyond healthcare. AI investment is not only a technology decision, it's also an operating model and data infrastructure decision. With that context, let's turn where this is all heading next. I have two-part question for you, Ümit, to close the conversation. Where do you think people are underestimating AI's potential in healthcare, and where are they underestimating the risks? And the second part is what needs to happen for healthcare AI to move from isolated success stories to a system-level impact?
Sure, I'll try to address those. So in my opinion, the clinical reasoning is one example to your first question. Reasoning optimized models significantly outperform standard LLMs on multi-step clinical tasks. In a study published in Science, the O1 preview model achieved clinically acceptable reasoning quality in 98% of cases, significantly outperforming attending physicians who achieved the same standard in 35% of cases under identical conditions. That number is designed to provoke. However, this is a controlled benchmark and not a real clinical encounter. So real medicine, as you can imagine, involves ambiguity, incomplete histories, patient-specific contexts that benchmarks don't capture. The point is not the AI outperforms physicians. The point is that the reasoning capability gap is closing faster than most clinicians expect. And that has implications for how we think about human AI collaboration in diagnosis over the next 5 years, for instance. So in diagnostic reasoning, to discuss around the risk, the reasoning at the front end of the encounter, recent benchmarks, including work published at JAMA and BMJ, consistently show that while AI excels at summarizing known data, its performance is generating accurate differential diagnosis for complex, uncertain cases remains significantly lower than senior clinician. It often misses the primary diagnosis in most challenging presentations. That's exactly the situation where we most need the good reasoning, and exactly where current models are least reliable. AI excels at the pattern matching, as you may know, toward a diagnosis rather than that's already been partially formed. So it struggles at the beginning of an encounter and then open-ended hypothesis generating phase where most diagnostic error occurs. So in other words, the practical boundary is to use AI to pressure test a working diagnosis. Don't use it to generate one from scratch without clinical scaffolding. So maybe I can move to conclusion. The physicians was never the problem. That was the message I'm trying to give here. The paperwork has been. So everything we discussed today, scribes, surveillance agents, predictive models, governance frameworks, library structure, is in service of one goal: returning physicians to the patient encounter. In my opinion, the 4 conditions for that to happen are human-in-the-loop governance built as architecture, not compliance, living governance that evolves with technology, and liability awareness built before the first case, not after. In other words, AI is not the end of physician, it's return of every reason to be.
Ümit, thank you. This is great. And before we open to questions, please put your questions in the Q&A box, by the way. Let me share a few takeaways from today's conversation. Ümit gave us a powerful frame at the start. AI in healthcare is not about replacing physicians. If you recall, he made the analogy, it's about excavating the administrative layers that have buried the patient encounter over the past 4 decades, that framing applies well beyond healthcare. What stood out to me is that the conversation has shifted. We are no longer debating whether AI works. The evidence is already there. The real question now is whether organizations can build the foundations to deliver on that promise that AI has and what AI makes possible. That's fundamentally a leadership change, and it's one that every industry is now actually facing, and we need to be prepared for this new era of where we are seeing the art of the possible with AI. So I'm going to summarize these in 3 takeaways. First one is AI is already delivering measurable impact. We have seen several examples from Ümit today. Healthcare AI is moving beyond research into operational use cases, including clinical documentation, patient monitoring, diagnostics, and workflow support. The second one is the hardest problems are operational, not technical. Scaling AI requires trusted data foundations, workflow integration, governance, and clinician adoption alongside stronger models. And the third key takeaway is AI transformation is an operating model transformation. Organizations that successfully operationalize AI will rethink and reimagine workflows, decision-making, and infrastructure instead of simply layering AI onto existing processes. Ümit, thank you again. This has been a rich conversation, and we will open up for questions now. Let me stop sharing and then pick up from the Q&A. The first question is, how can patients give truly informed consent for the use of their medical data in AI systems when most people do not fully understand how these systems process, share, or retain data?
I think it's a great question, and I'm not sure if we in the US address that consent issue. In my opinion, the health systems are the data custodians, but unfortunately, some are treating that they own the data, but data belongs to patients, right? So in many of the projects that I'm involved, we are pushing to make sure the patient permission and how we are going to be using their data is shared with them at the beginning. So for instance, some examples that we are working right now is using these AI models to consent lay summaries and translations. In other words, for the clinical trial, you have to sign, in most cases, you have to sign a consent, right? But unfortunately, those consents may be full of medical jargon and they may not be clear. And that is leading to early dropouts of the studies. Therefore, using some of these AI tools and opportunities to create a summary where patients with different literacy level may understand. So that those type of activities shown to be keeping people engaged in their care. And another one is, as we are developing these models, I think we definitely need to have patient advocates involved, whether the problem that we are trying to solve is something that patients truly care. I think those are the important points, but again, EU with the GDPR, of course, has different laws in place how those data can be used. And therefore, in my opinion, federated learning has been invested a lot in Europe, and we are trying to work with them in multiple areas where, especially some of the rare cancers, where we may not have enough sample size to train our models sufficiently. But in summary, it's a great point, but the push of having patients giving permission for those data to be used is important, and we are pushing very hard for those.
Thank you, Ümit. The second question is, what do you advise to organizations aiming to raise above the noise and make informed decisions while picking AI solutions and partnerships beside the EHR vendor offerings?
Great question. So I think, as I try to convey today, the promise is not how well AI model performs, right? What is the clinical outcome once we implement that into workflow? What are we gaining out of it? Are we reducing the burden on physicians or providers? Are we improving the trial matching or availability of trials? Are we reducing cost, or all of the above? Like looking at this as a total cost of ownership, not just a vendor coming greatest model ever and we want to implement this, but how much it's going to cost. Are we going to be able to have set of champions with the protected time so they can be the true champions, test these models, which certainly will have some errors and challenges that needs to be fixed, right? So I don't think there's one answer, but looking at comprehensively would be, I guess, the answer.
We have another great question from our audience. Equity is another important dimension here. If AI deployment depends heavily on existing infrastructure and data maturity, how do we avoid widening gaps between healthcare systems that are already well-resourced and those that are not? And how should organizations think about equitable deployment?
So that's a great question as well. The tools we discussed today are predominantly available in well-resourced academic health systems. And if we deploy AI where the infrastructure already exists, we widen every gap we claim to be closing, right? So the bias problem is more technically precise than people realize. LLMs trained on clinical notes inherit the documentation pattern of those notes. Race, socioeconomic status, and insurance status are encoded in how notes are written currently, which means they are encoded in what the model learns. Research published in Nature Medicine found that significantly lower AI diagnostic performance for patients with darker skin tones in dermatology, for instance, a disparity that persists even when AI-assisted decision support is introduced. So it's not hypothetical risk, it's measured evidence, in my opinion. Also, equity is a governance obligation, not a value statement, in my opinion. Prospective bias audits before deployment as a gate, not a checkbox, should be implemented.
That is a very good point. And that actually is a challenge across pretty much all of the applications with the image recognitions and pattern detections. We have a long way to go in terms of one, addressing the data bias we have, and also algorithmic bias and the equitability across the applications. I have another question. Ümit, 70+% use of AI-based predictive diagnostic use seems quite high. Is it really happening under regulatory supervision, or should we consider them early testing by institutions?
So the 70% is coming from what ONC has surveyed. As you may know, they are the EHR certification agency within the Department of Health and Human Services. So probably we need to look 70% as everything being implemented. It may not be the very well-functioning deep learning diagnostic tools. It's more of a predictive AI. It could be used for administration or billing reimbursement, if it makes sense. So I want to make sure we frame it correctly. It's not diagnostic, 70% of them using diagnostic purposes, but predictive AI model within their EHR.
Thank you. Another question is that you mentioned that many clinicians initially experienced AI tools as additional cognitive load rather than relief. How do organizations successfully move through that adoption curve?
So as briefly mentioned previously, I think we need to make sure we are giving the protected time for those practicing will attest to this, that they are already very busy, right? Trying to add yet another very innovative AI tool that is going to save time in the future is not giving a complete picture in the sense that they will not have enough time to fully validate, identify where human in the loop checkpoints should exist for an agentic AI implementation, for instance, right? Therefore, we need to make sure any implementation plan includes this protected time, at least for those champions that we discussed earlier. So we will have full validation of at each institution. Another one is there is this common saying within the US where if you've seen one EHR, one institution, you are seeing one institution, one EHR, right? Every institution, even same academic health system or state institutions, for instance, are different. So it's going to require, unfortunately, each health system to invest similar with the well-established plan.
Another question is, do you see similar difficulties when it comes to utilizing AI in health on both sides of the ocean, meaning USA versus the European Union?
So great question. So as EU has this AI Act now that is designating the clinical use as the high risk. So it's well defined in EU, while in US there are still regulations being set up. You may have seen FDA has released some guidance around this, and probably it's going to be increasingly become available. Some of you may have heard FDA has now a pilot where real-time clinical trial where they would like to receive the trial data directly from the health system without current process that is capturing data into CRFs and then harmonization of that data going to the sponsor then submitting to FDA, which is taking quite a long time. The point I'm trying to make is this is becoming more and more into the therapeutic advancements, and therefore I think we will see more regulations, or at least some of the guardrails on the FDA. And as a government employee, we are working with FDA to make sure we are defining those guardrails and collaborating truly.
And in some sense, also European Union AI Safety Act covers all global organizations, because even if you are a United States-based organization, if you have a specific number of employees in EMEA region, in European Union region, or if you have revenue coming from those regions, you will be bound by the EU AI Safety Act. And what Ümit refers as the high risk, that I want to underline that, because if these use cases become high risk, EU AI Safety Act high risk obligations are going to be rolled out August 2026, and it can impact up to 7% of the total revenue of an organization if they are violated. So we will see some interesting probably cases coming through once that is in place, but yet to be seen. We will monitor that. One more question. In the presentation, you mentioned that in ICU settings, AI can predict cardiac arrest up to 17 hours before it happens. Do you have data on patients outside the ICU? And how early is it possible to diagnose or predict cardiac arrest in those cases?
So in the example that I mentioned, I can probably share the publication I pulled that from, and it's not my expertise area. I found it very interesting, therefore I shared it. So they are using the wearable devices, right? So that is in the setting. So I don't think I know enough to answer that question, but I'm happy to share that paper.
Thank you, Ümit. One of the interesting, you talked about the medical devices. I noticed that in 2025, FDA approved, authorized over 1,300 AI-enabled medical devices, and compare that number to a decade ago, which was just 6. That was kind of eye-opening for me, how fast we are going A decade ago, it was 6 devices. Now it's 1,350 AI-enabled medical devices approved by the Food and Drug Administration. I have one question. This is an area that I keep thinking about. I was in a conference a couple of years back, and they were talking about some of the economics of clinical research itself. Pediatric cancers, for example, face a structural challenge, small patient populations, long trial timelines, and limited funding because the commercial return is limited. And that touched me deeply when I was in that conference, and I kept thinking, like, can we actually channel the power of AI to these use cases that will matter significantly? Can AI change that equation through areas like faster trial design, synthetic data, or identifying candidates more efficiently?
I think that's where the underestimated potential is probably the most significant. Like the pediatric oncology is the clinical example of a market failure in clinical research. The population are very small. Fortunately, hopefully we can totally eliminate it. But trials are long, and the regulatory pathway is demanding, and the commercial return doesn't justify usually the investment by conventional pharma economics. So AI changes three parts of that equation simultaneously. The first is the cohort identification. So a child with a rare sarcoma subtype, for instance, may be one of 40 patients in the country right now. Identifying that child, confirming eligibility, and getting them onto a trial currently takes months, sometimes longer than the trial window allows. So AI-powered screening across a federated EHR networks can compress that to days. That's the promise, and we are working hard on that. We don't need data to move. As I mentioned, the federated learning is an option there where we can move model to data. And that's, I think, federated learning going to make it possible at scale. The second, you mentioned the synthetic data, for instance. When you have 30 patients, you cannot power a trial, right? Generative models currently trained on existing patient trajectories can now produce synthetic cohorts that preserve the statistical properties of rare disease populations without creating privacy exposure. This doesn't replicate clinical evidence, but it can inform trial design. The third is the trial simulation itself. Before you enroll a single patient, AI can now model the likely outcome distribution of a trial under different protocol designs, helping sponsor and regulators agree on a design that's both feasible and informative. I think that reduces the cost of being wrong, which is the real barrier to rare disease investment. Just to clarify, synthetic data and simulation are tools for design and hypothesis generation. They don't replace the trial. I think the regulatory pathway still requires real patient evidence and cannot avoid, and we shouldn't avoid that. But if AI can reduce the cost and time of getting to a well-designed trial, the economic of rare disease research change structurally, not marginally, in my opinion.
That's promising. Thank you. What is your take on the top EHR? Let me just actually take that vendor question out. Do you expect AI native initiatives to surpass the success of AI flow implementations on existing system solutions?
So are you talking about the adoption curve on?
I am not sure. Maybe the person who asked can clarify. AI initiatives to surpass the success of AI flow implementations. Maybe you can make an assumption one way or the other, Ümit.
So,
Or let's ask the audience person to clarify that question. I will pick another one. I conduct global oncology clinical trials within the pharmaceutical industry. Thus, I ask the difficulties related questions because in my personal experience, EU is more strict compared to US. Okay, this is a commentary. Thank you. We talked about that. Another question is, how often do healthcare AI models typically need to be revalidated or updated? Is there a standard timeline, or does it mainly depend on factors like EHR changes, incoming data volume, or model drift? Also, how significant does a data or system change need to be before a model requires retraining or revalidation?
So great question. I don't think there is a standard like you have to retrain or revalidate your model every six. I haven't heard. There are some frameworks like the FAIR AI, the one I mentioned, and this model drift is a true problem that I'm not sure if there are existing solutions. For instance, ARPA-H, one of the government agency, has established a program called Precise AI, and unfortunately, due to some challenges, I don't know if that program is continuing, but that was trying to establish some benchmarks around the very same question. So probably it's going to change my use case. Therefore, as we are moving into the agentic system, having this golden trajectories and monitoring agents to see if they are following that golden trajectories and maybe setting a threshold where that golden trajectory is moving away, then re-evaluating probably the right way to approach this, in my opinion.
Thank you. We got the clarification. The question about do you expect AI native implementations surpass the layering AI into existing workflow type system solutions?
So great question. I think we need to look at the EHRs and how health IT is dealing with the EHR implementation. So unfortunately, we have an interoperability problem, meaning having a data within EHR and getting that out and interoperate with other data is problematic. Therefore, probably for institutions who may not have the budget and resources to make a implementation plan for an external AI system, it will be relatively easier to go with the one within EHR. And that's not going to require you to get data out of EHR, put in a, how can I say, in a format where this AI model can consume. There are a lot of challenges. So if I need to guess, I would say probably HR focused ones will win. But we need to therefore set these guidelines and frameworks in place, whether it's within EHR or outside, all follow the same guardrails.
Thank you. Last question. With China targeting standard AI-assisted diagnostic across primary level township clinics for 900 million citizens, will it create a new digital drivers in patient care?
So good question. So probably, as you may have seen in literature, that some of the biotech is already moving to China, and that is something I think in last 2 years they may have increased a couple $2 billion investment, while US and EU losing some of those investments. So China is coming with a lot of potential, and in US we are trying to address some of these inefficiencies so we don't lose that investment and the potential at US. So great point.
Ümit, thank you for sharing your expertise and your perspectives with us today. And please join me thanking Dr. Topaloğlu. And thank you everyone for joining and for great engaging questions. The recording will be shared with the TÜSİAD New York Network. We look forward to seeing you at our next AI Connect session.